have. And the pertinent question to answer is, does the patient require splint? If he requires, then we have to prescribe that, because if the limb does not require rest, it requires mobilization protocol as well. I'll run through a few of the first slides. Is limb elevation. I want to stress here is because all these patients were waiting for surgery, were waiting for evaluation, or probably just have got blunt trauma and require some immobilization and limb elevation. The thing is that the injured part should be splinted well, maybe in a position of rest, or as the injury has bears upon that. But at the same time, there should not be any constriction. There should be a pillow cover sling, which we prefer, and the elbow should be very well supported. So in anatomic consideration, we know that this is the line where we actually get the metacarpophalangeal joint. And so for the volar slabs or the volar splints, it should not be beyond this brown line for the MCP joint to be completely free. At the same time, it should be under to this particular line so that the thumb can be very well used. Jib position, metacarpophalangeal joint in 90-degree position, and the IP joint in complete extension. This is used in most of the surgeries, post-op surgery, post-op cases, and most of the acute injuries. And uh, one is a moldable splint. It should always be there. And we have also used POP and a Kramer wire for the same. So in most of the injuries where the patient is still waiting for the evaluation and investigation, we can immobilize in this position. In cases where we have flexor tendon injuries, as we have just seen, and cases where we don't want the extension of the finger in any way, we can use this particular way. The conservative for again, like a conservative management of fracture of phalanx, it in a jib joint position, and then mobilize in a body strapping. Wrist splint. So in cases where we have a blunt trauma, we have got synovitis at the wrist. In cases of a carpal tunnel syndrome, where we want the position of the wrist to be in 20-degree of extension, this wrist splint is handy. And we don't endorse any particular brand, but it has to be just proximal to the metacarpophalangeal joint to give the best results. It is also used for the post-operative therapies. So I at times use the same cast, cut it, and use it for further rest. This patient was having synovitis, and he was waiting for the synovial biopsy here. And in the ward, we had used this to give rest. The idea is that the pain should be patient should be relieved of the pain, because if that's the thing, then the other fingers he will be moving well, and he can also use the hand. Finger injury, we cord splint is good because it can be used when we want to save the fingertip from getting injured again and again. So if you have an injured fingertip and we don't want it to be to touch here and there, we can use a cord splint like a helmet. And it's also useful when there's a blunt trauma and we just want to give rest to the DIP and the PIP joint for some time and then mobilize them. Alufoam splint, I would say, as a workhorse for all the hand injury, for finger injuries, and can be used when there are phalanx fractures or the nail bed repair as a fingertip injury. And uh, many situations can be managed by a gutter splint. Here, it's like a PIP and a DIP are kept in complete extension, and it's just to give rest to that part. Maybe when there's a volar plate injury or when there is only a blunt trauma or a very undisplaced fracture, it can be used. It can also be used when we want to prevent the PIP joint flexion contracture. It can be used and for the same. I've put this example because just to stress that if we have got a fracture, we have reduced it and we don't have a splint, we have to make a point that we do something like we have used a syringe here to give a splint. So the idea is that to splint what requires rest and mobilize what is healthy. So again, a dorsal blocking splint. So this splint can be used very well where we want to, so this proximal phalanx, there's a PIP joint fracture dislocation. It has been reduced. And now we want to mobilize at the same time, give an extension block here. So this splint is in a slight flexion here. So the finger is kept in flexion. At the same time, the distal part is in Velcro, so it will be removed. The finger will be, the patient will exercise at the PIP and the DIP joint and again use it. And the angulation here will be gradually decreased so that at the end of the 4 weeks, the finger will be completely straight, and this will be enough. This works very well for the conservative management of the fracture dislocation of the PIP where it has been reduced and now we would just want stability at the same time. start mobilizing at the PIP and the DIP. Captain's splint is favorite of hand surgeon. We have discussed it throughout the day. Morning we have, I'm sorry, in the earlier sessions we have discussed it. So it's for the conservative management of the central slip injury, the zone 3 of the extensors. The idea is that the PIP joint is kept in complete extension, and the DIP joint is completely free. And the patient, for the central slip injury, he wears this splint and he does a PIP joint movement, does not do a PIP joint movement, but does the DIP joint movement continuously, so that the volar subluxation of the tendons, lateral bands don't happen. And it's quite reliable, but it has to be worn for a long time. It's also very much useful for flexion contracture, maybe because of a post-operative case or a volar plate injury, and then leads to a flexion contracture at the PIP. It's useful. Mallet finger, very well discussed by Nete sir already, but I generally manage them with this particular type of splint. So for a soft tissue mallet, the splint is in 15 to 20 degree of extension, and we keep the splint for 6 weeks, 4 to 6 weeks, 24 hours, another 4 weeks for at night time. For bony mallet like this, we take a lateral X-ray, we see this, we put a splint, and then we take an X-ray with the splint on. If the bony fragments come together or they are just nearer to each other, that means it's going to work, and the protocol is the same. Some people prefer to put it on the dorsal aspect, and this is a 3D designed splint from KMC Manipal that can be also used. Trigger finger, interestingly, in the earlier stages when there is inflammation, when there's just pain, or in the situation where there's occasional triggering, we can use the splint. It just blocks the MCP joint flexion, and definitely it eases out the FDS. It relaxes the FDS for some time. FDS and the FPL for some time. And again, for giving rest to the FPL, we can use this simple aliform splint. I prescribe this for 3 to 4 hours in a day for about 14 to 21 days. There are papers which describe it as a night splinting for the same time. Thumb splint, decurvent tenosynovitis can at times be managed very well by just rest to this part. So thumb spica splint, where we can give rest to metacarpal phalangeal joint, carpal metacarpal joint, and also the wrist area where we want to give rest in the decurvent tenosynovitis problems can be very well used. In situations where we just want to manage conservatively fracture in the phalanx region or in the metacarpal region of the thumb, at the same time keep the wrist completely mobile, we can use a customized type of splint here. Carpal tunnel, as I've said, in early stages, in the cases where the patient has got the sensory symptoms only when there is a volar flexion of the wrist, it can be used for night splinting. At times, it can be used 24 hours. The patient, if the patient gets relieved of the symptoms by this, it's very good. Nothing has to be done later. So, nerve injuries, we have splints, and basically, we have to consider three things in nerve injuries mainly. One is that the paralyzed muscles have to be kept in a position of relaxation. They should not be overstretched, and till the time that either they recover or we do a tendon transfer. Second is that we want to prevent any undue contractures because of the motor loss of one group of muscles. And third is that there will be some altered sensation in particular area, and that has to be taken care of while we design these splints. So this is a palmar abduction splint of the median nerve, and this is the palmar bar. So this can be without a bar or we can be with a bar there. Radial nerve palsy, I prefer to use only a splint which has got a dorsiflexion of over 20 degree at the wrist, and the fingers are kept free, the MCP joints are kept free. The idea is that the intrinsics will be taking care of the finger of the extension of the IP joint, and there will be some patient will keep on working, will move his hand and fingers, and we wait till the radial nerve recovers or we plan for a tendon transfer. We have to be very cautious if we are using this particular type of splint where we have a passive extension and the patient is supposed to do dynamic, patient is supposed to do active flexion. Sir, 2-3 minutes, I'll take more. Pankaj sir.
Yeah, sure, go ahead.
Yeah. So if the patient is not going to come to us every day, And if we are not sure that this is going to work, it's not a good thing to manage patient with this passive extension and active flexion, because they may develop contracture at the MCP joint here. The concept for the knuckle bender splint is to correct the clawing in the ulnar nerve palsy, also to prevent the clawing in the ulnar palsy. At the same time, the patient can strengthen his flexors here because they are free. Dupuytren contracture, we use a pan splint which keeps the MCP joint in complete extension, the PIP and the DIP joint in complete extension. This is a post-operative splint, and once we release it, we have to put the patient on this, and the patient removes it and does his exercises again, and again puts it on. I have used another way of making the same thing, but this is commercially available. Body strapping is of great help for the conservative management and also for the rehab in cases of fractures, injuries of the metacarpal and phalanx as well. In cases of blunt trauma as well. The idea is also it is useful when we have done a tendon injury, tendon repair, and then this can be body strapped to an adjacent normal finger, and it helps in the excursion of the tendon when the patient is mobilizing. So the point here is that there has to be a gauze piece between the two fingers so that there is no maceration, and at the same time we have to keep the joints free. If the patient is doing the strapping himself at the home, then preferably he should do it in a with a paper sticking so that it's not tight, too much tight. Last few slides. So metacarpal phalangeal joint stiffness, we can use a digital loop, finger loop thing here with a rubber band and a safety pin on this side, so it causes continuous traction at the MCP joint. At the same time, patient can do a active extension as well. And the point is that all the fingers, uh, uh, they point towards the scaphoid. So all these rubber bands will go towards this side. So this is an OPD thing which can be done, and it's always handy to have rubber bands and safety pin and Velcro with us in a pocket. This is another way of doing this, but then this strap, we have to understand that it has to be very narrow so that the metacarpophalangeal joints are free. This is for an individual finger, it has been done. For stiffness of the IP joints, we can use a glove thing, which is the part of the fingertip here is cut, and then we force the IP joints into flexion, and then we can use it. Similarly, this can be done in this way. Uh, yeah, I thank you. Thank you. This is the end of it.